Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about research into optimizing the delivery of cancer care with Dr. Jacquelyne Gaddy. Dr. Gaddy is an assistant professor of medicine and medical oncology at the Yale School of Medicine. Here's Dr. Weiner.
I always like to get started just asking people a little bit about themselves. Can you just tell us where you're from? Where'd you grow up? Where'd you go to college and medical school? Just a few words about you.
Absolutely. Many may not know, but actually I was born in Los Angeles, but moved to Buffalo, New York shortly thereafter, which is where my family is mainly from. So I was raised in Buffalo, went to high school there, raised by my mother and my grandmother. And after high school, I went to Spelman College, which is a historically Black school for Black women in Atlanta. And I then went on to get my master's at the University of Buffalo with Roswell Park Comprehensive Cancer Center. And for medical school, I went to Loyola in Chicago. Residency training was at University of Buffalo. And then my last stop for my training was at University of North Carolina for my medical oncology fellowship.
Well, and we're very glad you wound up with us, and you've been here in New Haven now for somewhere in the range of 2.5 years, if I remember correctly. Would you mind just telling us a little bit about the influence that going to a historically Black college had on you and your decisions about how you would pursue your career?
Absolutely. Being raised in Buffalo, which if you haven't gone to Buffalo, you may not know, but it is a really segregated city. And in different parts, you find different type of people. And when I went to high school, in many ways, I felt like I was different. I felt that I didn't fit in. I didn't see many women that looked like me, that had the same dreams and aspirations. Although my mom certainly did her best to make sure I was involved in just about everything as a child, I knew that I wanted to attend a school that I wasn't different, that I wasn't the only, and that I would be surrounded by others that were like-minded and that would ultimately cultivate me to a woman that could go into the community and environment and be successful. Although I knew once I got into my career that everyone may not look like me, but being somewhere where I was believed in at Spelman, I really would say developed all the parts of who I am today as far as like my professional development and things of that nature.
And you focus on gastrointestinal malignancies, is that correct?
That is correct.
And maybe more specifically on colorectal cancer?
Yes. I would say that about 30% of my practice for sure are patients that have been diagnosed with colorectal cancer.
All right. And what made you interested in gastrointestinal cancers?
Well, it would be about 9 years this coming November 11th that my late grandmother passed away from pancreatic cancer. So November 11th. And as I said earlier, my mom, who is a single parent, was blessed to have my grandmother alongside her in my upbringing. And my grandmother, who was the oldest of 13 siblings, she was not in the medical field, but if you saw her throughout her life, you really would think that she was a nurse or someone in that field, because oftentimes our sickest relatives would come spend their final days, their final weeks within our home. And because of that, I grew up having this high level of curiosity, especially in science and certainly in end-of-life care. And when my grandmother was diagnosed with pancreatic cancer, I was in my final year of medical school. And just by the grace of God, I actually was on an away rotation at the University of Buffalo, which afforded me the opportunity to be home with my grandmother nearly from time of diagnosis to time of death, which means that I was able to provide all of her end of life care in her home. And that opportunity, it really, I would say, solidified my decision to pursue a career in internal medicine, in medical oncology, and then ultimately to become a gastrointestinal medical oncologist.
And I know you're interested in research related to colon cancer and other GI malignancies, but you're also very interested in how we deliver healthcare and how we deliver healthcare to people from underrepresented backgrounds. Can
That's
you
correct.
speak for a minute or two, or however long you want to, about your sense of what it's like to be a person of color getting cancer care and how that's different from somebody who may be white?
I would say my grandmother, for instance, had she not had a granddaughter that was in her final year of medical school, I'm nearly certain that her experience would have been different. When you don't have someone that is in your corner as an advocate from the medical field, it is oftentimes that implicit biases and structural racism, microaggressions, and macroaggressions can unfortunately impact and hinder care. I think oftentimes patients of color have been labeled as those that are mistrusting of the healthcare system, as opposed to saying that as a healthcare system, we have not been trustworthy, which is a completely different vantage point and way to approach it. And I think that people of color are often scared when they walk into an oncologist office where this is their first time hearing about cancer. They don't know how to navigate the system to get from one point of care to the next. They don't know necessarily what a clinical trial is. It may not be offered to them. And I think my hope as a young faculty member and a young oncologist is to try to ensure that minoritized patients really receive the care that they deserve, that often their white counterparts are easily receiving.
And I like the way you expressed that whole idea about trust. Of course, it's very easy to understand how it is that someone who is does not look like the people who are taking care of them feels just a bit put off. And in fact, I think that that that's not coming from them. It's coming from really their experience and from the system.
That's absolutely correct.
Yeah. So the statistics are pretty dramatic. A survey done a few years ago among U.S. oncologists um, showed that 3%, or actually a little less than 3%, of oncologists in the United States are Black, under 5% are Hispanic. And that just isn't what our population looks like, either in Connecticut or, for that matter, around the country.
No, it's far from it.
And one of the things I've wondered about is, and I'm really interested to get your take on this. Is it critical that the person who's taking care of somebody with cancer look exactly like them, or is what's important that the whole system feel a little bit more diverse, so that when a Black woman or man is getting treated for cancer, they're not being treated by an entirely white staff?
I think it's more so the latter. While I definitely believe there is value in racially concordant care, meaning when I walk into the room and my young Black woman that has just been diagnosed with stage 4 colorectal cancer lights up because for the first time she's seeing a provider that looks like her, I think immediately barriers are broken and it's just a little bit easier to provide care in those settings. However, if a patient walks into the cancer center and they are greeted by staff members that may look like them, or the nurse may look like them, or the research associate that counsels them as they consider enrolling into a clinical trial. I think it's really the diversity of the entire system and the ability to be culturally competent, to have a level of authenticity, along with understanding that while you may have certain privileges that your patients may not, and trying to use your privileges to assure that your patients receive equitable care is what is most important.
And can you comment about what it feels like for you being a Black woman in oncology? So, we've talked about the patients, but we haven't talked yet about how your experience is, and to what extent you think that experience is different from others.
Absolutely. So since leaving Spelman in 2008, most rooms that I have walked into, whether it be my medical school interview or my fellowship interview or presenting at a conference, it's very easy for me to be the only woman of color in the room. And now, after some years of training, I have certainly gotten used to it. However, at times it's challenging, where I have to make sure that I carry myself in a way that, and sometimes I feel like I'm representing other women of color. Considering it's only 3% of us, it's easily to know who Dr. Gaddy in oncology is because there's not many other Black female oncologists, especially Black female gastrointestinal oncologists. I think my experience has been enhanced thus far by supportive mentorship, by being at an institution that the color of my skin has not made me feel like I'm less than in any way. Instead, it's been considered an asset to the institution, allowing my viewpoints to shape some of our decisions here at the Cancer Center certainly has helped my evolution and my overall professional expertise thus far.
And have you thought about how your presence on the faculty as an oncologist with other oncologists affects the way that white oncologists both interact with each other and interact with their patients? What's the impact of having a diverse workplace?
I think the impact of having a diverse workplace is having different viewpoints, that it's not just one homogenous viewpoint of white individuals or of just Black individuals, of being able to speak from a background of where I came from in the inner city of Buffalo, to encourage others to recruit those that may look like me, to treat their patients from a culturally competent standpoint. Overall, I really think it enhances a cancer center to be diverse.
Well, we're going to take a brief break. We'll be gone for just a minute. When we come back with Dr. Jacquelyne Gaddy, we're going to be talking about some of the advances in gastrointestinal malignancies, talking about clinical trials, and we'll be focusing a little bit more on the patient with GI cancer.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where 16 locations across the region provide patients with individualized, innovative, convenient, and comprehensive care. Find a Smilow location near you at smilowcancerhospital.org. Genetic testing can be useful for people with certain types of cancer that seem to run in their families. Genetic counseling is a process that includes collecting a detailed personal and family history, a risk assessment, and a discussion of genetic testing options. Only about 5 to 10% of all cancers are inherited, and genetic testing is not recommended for everyone. Individuals who have a personal and/or family history that includes cancer at unusually early ages, multiple relatives on the same side of the family with the same cancer, more than one diagnosis of cancer in the same individual, rare cancers, or family history of a known altered cancer predisposing gene could be candidates for genetic testing. Resources for genetic counseling and testing are available at federally designated comprehensive cancer centers, such as Yale Cancer Center and its Milo Cancer Hospital. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner with Yale Cancer Answers, and I'm speaking tonight with Dr. Jacquelyne Gaddy, a gastrointestinal medical oncologist. So a medical oncologist who takes care of patients with colon cancer and pancreatic cancer and gastric cancer and other cancers that arise in the abdomen. Jackie, we've had a great conversation so far. I want to focus a little bit more on some patient issues and some advances in research. So what has changed in the last 5 years when it comes to treatment of either colorectal cancer or GI malignancies in general? And after this, we'll touch a little bit on some of the changing epidemiology in colorectal cancer as well.
Absolutely. I think the first time I was exposed to oncology was when I was a graduate student. So this is going back 2008 to 2010. And I remember the textbook. And while many of those facts are still relevant as far as the cell cycle, but there was probably nothing about immunotherapy that was found in that textbook. And now, some years later, that certainly has had a great impact on nearly all gastrointestinal malignancies. Unfortunately, not yet in pancreatic cancer, but certainly in hepatocellular cancer, certainly in upper gastrointestinal cancers, so those of the esophagus and the stomach as well, and depending on your pathology, even in the colon. So we certainly have seen advances from an immunotherapy standpoint. We also are starting to see a lot of targeted therapy have greater advances in the space of gastrointestinal malignancies, especially in pancreatic cancer. So I will say, for a field that in many days I would imagine was considered hopeless, I would say we are in a space of being hopeful in GI cancer treatment.
Well, that's great. And for our listeners, could you just comment a little bit about what targeted therapy is, excuse me? What is it that we're targeting with targeted therapy?
Absolutely. In current modern medicine, precision medicine is so helpful in the sense I always explain to my patient, just like we have a fingerprint and it's very unique to our identity. In many ways, cancer similarly has a fingerprint, and its fingerprint is its mutational profile. What mutations are present, what are not present, and certain mutations that may be present in a patient with cancer, especially in advanced cancers, may allow a certain drug to target that particular mutation that in ideal settings would downregulate the cancer growth and potentially slow the growth of the cancer and in many ways enhance survival. One of the receptors, or one of the mutations, that I should say, for instance, is KRAS. And KRAS is something that's really important right now in the space of pancreatic cancer, where patients that have particular KRAS mutations will have the opportunity to have drugs that target these mutations.
Sure. And then another example that some of our listeners may be familiar with is HER2. HER2 positive breast cancer is something that is fairly common and accounts for about 20% of all breast cancer. But what people may not know is that a small proportion of colorectal cancers are actually HER2 positive as well. And if I'm not mistaken, they can benefit from some of the drugs that are used for breast cancer and other HER2-driven malignancies.
That is accurate. And similar, that is also considered targeted therapy, which is why a patient's mutational profile is so important to really understand what exactly the pathology shows. Does it express HER2? Does it express certain markers that would suggest there is a high chance of responding to immunotherapy or other agents?
Sure. Let me ask you about something else that's been very much in the news over the last few years, and it's been in the news because it's really a big problem, and that is the increasing incidence of colorectal cancer in younger individuals, people under the age of 45 to 50. Colon cancer used to be something that we associated almost exclusively with people in their middle age or older. And that's changed quite a bit recently.
That certainly has changed in recent years. Actually, in the last 3 years, 2021, colon cancer screening for average age or average risk patients changed from 50 to 45. And much of that was influenced by recent years of seeing that the age of presenting with colon cancer is much younger than it used to be. And the etiology of this is still unclear, but much of this is thought to possibly be a result of diet, to be a result of other environmental factors. And what I would say is that the disparities from a racial standpoint that we see in colon cancer, we are seeing those same racial disparities amongst patients with early onset colon cancer, meaning that more patients of color are presenting with early onset colon cancer.
Yeah, and one of the big concerns is that in younger individuals, and this is true of colorectal cancer and it's also true of other malignancies, because young people don't really think of themselves as being at risk for cancer. And for that matter, many doctors never want to diagnose a cancer in a young person and think that it's very unlikely that oftentimes these cancers are found at relatively late stages where treatment is much more difficult.
Yes, and that's why when I counsel the community on colon cancer, I stress the importance, number one, of having a primary care doctor, of being aware of screening recommendations and knowing that what your family history is. And if you are 45, certainly making sure that you are starting your colon cancer screening. Absolutely. But if you're younger than 45 and you're having new GI symptoms, such as new abdominal pain that you really can't understand the cause, or bleeding found in your stool, bright red blood or dark black stools at times, significant weight loss. These are things that should make one think that maybe an earlier colonoscopy or other testing would be appropriate.
And what do we know about the uptake in screening in populations that are underrepresented? Do Black and Hispanic individuals have the same screening rates as people who are white?
In recent years, we have certainly improved the previous disparity that was appreciated in screening. There still is a disparity, but the difference is not as marked as it was in earlier years. However, we still have a significant way to go. I think this recording is so important and it's very timely that just yesterday the FDA approved a blood-based testing for colorectal cancer for patients that are at average risk and 45 years of age and older. And for some patients that, let's just say, they don't have transportation to get to a colonoscopy, or they don't have a way to miss work, or any other reason that would cause one to not be able to easily get to a colonoscopy, patients are excited to hear about blood-based testing along with stool-based testing.
And to be clear, that would be the first line of defense. So if something were found on that blood-based testing, or for that matter, on stool-based testing, that would then, in those selected individuals, lead to a colonoscopy. Is that correct?
Absolutely. It's the first line of defense that would alert your provider to say further testing is needed with a gastroenterologist to undergo a colonoscopy and likely other imaging of your abdomen along with your chest, depending on the findings. That would just be the start of other testing for sure.
But it also does possibly allow a large number of individuals to avoid tests like colonoscopies by doing other tests first.
That is true.
Can we move on and talk a little bit about clinical trials? So clinical trials are, of course, critical in moving the field forward. As I often say, there's no drug that was ever developed in a laboratory and made it to a pharmacy shelf without a big clinical trials step in between. Talk a little bit about clinical trials in GI cancers and perhaps maybe talk first about what are often considered the most advanced clinical trials, that is phase 3 clinical trials, in which there's often a randomization.
Absolutely. When thinking about phase 3 or later stage clinical trials, when I walk into a patient's room, I would say actually probably the day before, if I'm walking into a new patient's room or a patient has unfortunately progressed on scans, the first thing that I'm going to do is see what trials, if any, are available for that patient. It doesn't matter how old this patient is, what the color of their skin is. I'm first going to see what is available. And then based on availability, I may scan through and see, okay, is there certain criteria that this patient may or may not meet? And for me, that is my usual approach for clinical trials, that I make sure if it is available, that I am having that conversation with my patients. And unfortunately, what we have seen is that due to many factors, many patients, especially minoritized patients, patients of color, are not being asked or told about clinical trials. And what studies have shown is that when patients are asked about enrolling in clinical trials, they are more than willing. But of course, if you aren't asked, if you are not offered a trial, you really have no way of enrolling.
And phase 3 trials are trials that are really testing the standard treatment versus something that a lot of people think in one way or another could be better. Oftentimes, I think patients are concerned that clinical trials are something that are too experimental. But in a phase 3 trial, typically half the patients are getting the standard treatment. The other half are getting something that, again, many people, although it's no absolute guarantee, think could be better. And this is what moves the field forward.
That's correct. And I think, as you have just eloquently described, I think having that same conversation with your patient, truly describing just that this would be an advance in the field. This is how you would be impacted potentially, and really taking the time to make sure your patient understands that.
Dr. Jacquelyne Gaddy is an assistant professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.